righty, perfect. So I'll try to get through this pretty quick. So I'm Mike. I'm a PGY4. I'm the academic chief resident here at Tower Health. I also have Dr. Emma Twiggs-Cryer with us today. She's one of our brand new PGY2s. So we're going to tag team this. I'll get started on some quick initial slides. And then Emma's going to talk more about the intern year that we have here, as we are a categorical program. And I think it's changed a bit since I went through it. So she'll talk about some of that recent stuff. So really quickly, we are a categorical program. I was actually the first categorical year. We're located about an hour outside of Philly in West Reading, Pennsylvania. And with that, I will get started. So this is our rehab hospital right here. So we are a standalone 111 bed facility. 61 of those beds are acute rehab. So the other beds are actually, the other beds are on the second floor. That's going to be our transitional subacute unit. Residents are really only managing the 61 beds at acute rehab. State-of-the-art therapy, as you can see here. We do have, I think one strength of our program is that we have our inpatient and outpatient rotations all under one roof, with the exception of pediatrics, which is going to be done at Good Shepherd, about 30 minutes away, and as well as consults. So our consults will be done at the main hospital, which is where you do your intern year. That's about a 10-minute drive from our rehab hospital. You can see here I'll try to highlight some things as I go through this, but in terms of our outpatient office, we do a ton of EMGs, a lot of injections, a lot of ultrasounds. I can tell you now as a PGY4, so I hit all my numbers right at the end of PGY3. So that's all the EMGs, all the injections, all the Botox, got that done nice and early. In terms of ultrasound, I know that that's very popular now in PM&R, especially with so many people having an interest in sports medicine. So Dr. Sam, our PD, he is great with that. So he actually meets with all the outpatient residents that are interested in that basically every day of the week. So we usually start outpatient clinic at 8 a.m. At 7:30, he's there going over, they'll pick a joint, whether it be the shoulder, the knee, the wrist, the elbow. They'll do an entire scan and kind of go over some things and some high yield anatomy things to know for boards and things of that nature. Other thing that's nice about the rehab is we do have an indoor therapeutic pool. We also have a driving simulator, so we do all that right on campus here at the rehab. Parking's free, so we have a ton of parking at the rehab. I know some hospitals make you pay for that, which is kind of outrageous. Very cordial environment, I think, is something I want to highlight with our therapists, with PT, OT, speech. So everyone gets along very well. It's a good kind of mix of people, and we do things obviously professionally, but as well as socially. So there's some things I wanted to highlight with that. So our acute rehab unit, so this is pretty much run by the residents as well as the attendings, the PM&R. So we are the primary team down there up in the subacute unit, which we'll talk about on the next slide. That's going to be run mainly by hospitalists and internal medicine. So down on ARU, PM&R is a primary team. We do have on-site hospitalists as well as all the consultants from the main hospital, from infectious disease to cardiology, nephrology. They all come in and do consults over at the acute rehab. Average census you can see here is 56. Every service that a resident will be running is between 12 to 13 beds, with the exception of TBI. I think it's a little bit less. I believe it's 10 or 11. More or less, it's going to be full at all times. Attendings have been great in terms of helping out with admissions if things get a little bit hectic. Didactics time is fully protected, so any admissions that are scheduled during didactics time is covered by the attendings. Our services are split up in terms of diagnoses. So one wing is spinal cord injury. We also get a lot of multiple sclerosis on that side. Occasionally we'll get some ALS. We have a stroke service, which is pretty much pure CVAs. We have a TBI service, which is actually a locked brain injury unit up on the second floor. We have a medically complex unit that's kind of just a hodgepodge of different diagnoses. And then we also have an amputee service. One thing I did want to highlight just with all those inpatient services is all of our attendings, we basically have someone boarded in every subspecialty of PM&R. So we have brain injury, we have spinal cord injury, we have multiple people boarded in electrodiagnostic medicine. Yep. And then you can see again, just that's a picture of one of our downstairs gyms. So down in ARU, we have two different gyms, one on the east side, one on the west side. That is probably not the best picture, but it does have a very good view just kind of out of the valley. So this is going to be our transitional subacute unit. So this is just going to be upstairs. So we don't formally rotate up there. However, we do consults up there every now and then. And the reason I wanted to highlight that is just an opportunity for us to get more procedures for anyone that's interested in things like that. So again, it'll be a hospitalist is going to be the primary team upstairs. However, we do routinely get consults to go upstairs in terms of doing pain management consults, in terms of managing medications, or whether that be injections. So I know I myself have gone up there a ton of times, and it definitely helps to hit those numbers a little bit quicker. And if that's something you're interested in, you'll definitely get a lot more hands-on experience with that. And then the other thing I'll highlight with that is on the inpatient side, on the acute rehab side, downstairs. So our attendings are very good at finding us injections on the inpatient unit if that is something you're interested in. So you're routinely doing injections not only in the outpatient office, which is next door to the inpatient stuff, but you're getting a ton of exposure to that stuff on the inpatient side as well. We'll also, Dr. Gleason is really great about it. He'll actually have us do Botox on the inpatient side as well. So not always reimbursed by insurance. Actually, it's never reimbursed by insurance on the inpatient side, but just for sake of learning, and if it helps benefit the patient and get them through their therapy, he's very open to considering doing that on the inpatient side as well. Really quickly, I'll talk just about the PM&R schedule that we have here. So intern year will be the next slide. Emma's going to talk about that a bit. One thing I did want to highlight with this is that you do get a lot of outpatient exposure as a PGY2. So you're going to get a total of 4 months of outpatient as a PGY2. Bulk of PGY2 obviously is inpatient. I think that's how most programs are set up. But we do 2-month blocks, which I personally really like. It gets you time to kind of see the patient from when they get there and kind of see how they progress through their rehab. Gradually, as you progress through the curriculum, you'll get less and less inpatient. You'll do more of, EMG and outpatient procedural stuff. Another thing I did want to highlight here, you can see here on the PGY4. So one of the things in our curriculum last year was we actually did 3 months of EMGs as a PGY4, and then we still did 2 months as a PGY3. We have no problem hitting our numbers here, and we have a lot of residents who are interested in things potentially outside of EMG. So our attendings here were very receptive to us kind of voicing our opinion about that, and they've actually now created down here, you can see here just a selective. So we have an elective and we have a selective as a PGY4. So you can do your elective inside of Tower Health. You can do it outside of Tower Health, out of state if you want to. A selective has to be done within Tower Health, and you're kind of have the autonomy to structure that however you would want. So just kind of example of what I'm planning on doing with that. I'm very interested in spinal cord injury. I'll be doing a spinal cord fellowship. One of the things I want to get a little bit more exposure to is wound care, but I also want to do some more procedural stuff. So they're basically allowing me to, during my 5 days throughout the week that I'm working, I'm going to be doing probably 2 days of wound care, 2 days of procedural stuff with our interventional pain doc, which is recently hired on. And I'll probably be doing like 1 day of research. And I think that's super great for anyone that has broad interest, just because it really allows you to help structure the curriculum to get exposure to things that you want to do, while also kind of still learning everything you need to that are relevant for PM&R boards. In terms of our call schedule, you can see here, so it's front heavy, and then as you progress through the curriculum and your years, you'll do less and less call to the point where you do no call as a PGY4. I will say I really enjoy doing that. We have the call split up where it's not super unbalanced. So the numbers, I want to say it's like 5 or 6 weeks as a PGY3, and then you'll do 10 or 11 as a PGY2. It's like plus or minus 1, I would say, on that. I'm not sure the exact numbers. We have one resident that will basically take at-home call Monday night through Friday morning, and you never have to come in. You'll never be asked to come in overnight for anything like that. You're just answering pages. And then we have a second resident, so a different resident that works Friday night from home. They're in-house Saturday and Sunday during the day, and then they're on call Saturday night, Sunday night, and they're done on Monday morning. What's nice about that is the resident that is working the weekend and in-house, they actually get a half-day comp day on Monday. So if you're on an inpatient service, you'll round on your patients in the morning. You're not responsible for any admissions, and then you get to go home for the day after that. So I think that's super nice, and it kind of gives you a good work-life balance. And now I am going to turn it over for Emma for this slide.
Okay, so I'm going to talk to y'all a little bit about the main hospital. The main hospital, as you can see here, it's actually the busiest hospital in Pennsylvania. It is so Reading is about an hour, 20 minutes outside of Philadelphia, and it's kind of in the heart of a few different like farming communities, and just it services a huge area, making it a really busy hospital. And with that, it is the 10th busiest in the United States, which I actually found pretty surprising as well. And the level one trauma center, which is really good because then you can, I mean, unfortunate for the patients that are in traumatic events, but good for us in that we get a lot of exposure to different things, especially when they filter down to our rehab center. The hospital itself has 700 beds, and 70 beds in the ICU. There's a SICU, surgical ICU, and a medical ICU, which we have the opportunity to work in both. Um, Everybody there at the main hospital has been very welcoming. There are lots of residents there, but there are also a lot of just regular working attendings. But it's been a really good balance. The residents have the opportunities to learn from, of course, their residency program, but other attendings that they can ask questions to as well. Plus, the other services involved are very welcoming and helpful and are always open to answering questions. It's also a little hard to navigate at first, and I got lost multiple times, and there was always a friendly face to show me where to go, which was very reassuring when you're trying to navigate such a large hospital. Talking about the healthplex here, so that's kind of one section of the hospital. It's near the emergency room and kind of the surgery center. In the healthplex, it says operating suites. Some other cool things there. They have a not a food court. We have one of those kind of in the main section of it, but there's a Starbucks down there where you can get snacks like kind of in the middle of the night. If you're there, which you won't be as an intern in the middle of the night unless you choose to be there. Well, no, I take that back. During emergency medicine, you might. Um, anyway, there's a lot of fun things out there. There's access to a really nice garden, just kind of on the ground level. And then it mentions in the slides too, there's also a rooftop garden, which you don't necessarily have access to, but you can see it as you're going up and down in some of the different floors on one wing of the hospital. It's really nice. There's a larger food court. The food is pretty good. It's not bad. They have a decent variety, and you also get a stipend, which is nice, and you can use that stipend during your intern year. You continue to get the stipend throughout the rest of residency, but while you're on the main campus during the intern year, it goes directly to your ID, so you can use it in the cafeteria, and then once you are at the rehab center, they put that money into your paycheck instead. So you continue to get the benefits of the stipend, but you have to bring your own food. So not a big deal. All right, next slide, please.
Okay.
So during intern year, you get to rotate through a few different services. The biggest one that you rotate through is internal medicine. We do 3 months of internal medicine plus 2 weeks of orientation at the beginning of the intern year. During those internal medicine months, you are working with the internal medicine residents as well. There's the structure is normally two to three interns, and then one senior resident on the team. So the interns are you as PM&R plus at least one internal medicine resident, and then maybe another internal medicine or neuro or anesthesia. I think OBGYN does it as well. So there's a smattering of different services you get to work with on internal medicine, like as a team. And then you work with an attending, and they switch off during the week. The schedule is not terrible. You are there about 6 days a week, but you don't have to work any nights. And the latest you're there is normally 8 p.m., and that's about every 4 days. Another service you get to do is rotate on the trauma service. That is split into kind of two sections. With that, you get 2 weeks of SICU, the surgical ICU experience. And then after that 2 weeks, you work on kind of just the trauma med surge floor where most of the surgical ICU patients are downgraded to. So you can kind of get some continuity of care there, which is exciting. Then 1 month of inpatient pediatrics, it's just like it sounds. All the pediatricians are wonderful. It was one of my favorite rotations. You do 1 month of neurology. With neurology, that one's kind of divided into two sections as well. You do about 2 weeks of general inpatient neurology and then 2 weeks on stroke. During that rotation, you do have to work weekends. Only two though, at least that's what our year did. We only worked 2 weekends and those were kind of scheduled in advance. So it was nice if you had some scheduling needed to plan for those. Then you do 1 month of emergency medicine. That one's also a possible weekend one. And this is the only rotation, at least for us, we had to do a couple nights on emergency medicine. But I only did 3, and I think that was the same for my other co-residents on that level. And then the other time is just kind of the schedule you follow with an attending, and there are emergency medicine residents there as well. You don't necessarily work with them, but you're all working in the same area, so you can collaborate. And I must give a shout out to the emergency medicine residents because one of them is my husband, and they're all really great to work with. Then you do 1 month of neurocritical care. That one you're getting exposed to the surgical ICU and the medical ICU, your consult service, and I thought that that one was also very helpful. And with a handful of those, they'll eventually end up in the rehab center, so that was kind of cool to see the continuity of care there as well. You do 1 month of PM&R, that's divided into 2 weeks, just kind of wherever your schedule needs it. And then 2 weeks on orthopedic surgery. For that one, you were primarily in clinic. And then 1 month of neurosurgery, which I also really enjoyed. This one you can kind of structure to being more in clinic, or you can go participate in the surgery. And I was able to scrub in every surgery and help out for a couple of them as well, which was very exciting.
Sorry, I didn't want to interrupt your flow. I'm going to give you guys a couple of minutes to kind of wrap it up, and then
Yeah, I'll hit the next couple slides really quick, the high yield stuff. So really quickly, just talk about the scholarly activity. So we were very well supported in terms of that. You get PGY 1 year, you'll get $1,000 for CME credit, which is usually enough to cover your step 3 or your COMLEX 3. Starting PGY 2, you'll get $2,000 per year for CME. It's obviously enough for at least one conference. There's actually opportunities to get more CME money if you need it and you're presenting at conferences. We've had residents publish original research. We work with Drexel very closely with that. We've presented at local as well as national conferences. We're usually at AAP and AAPM&R. Benefits, you can find all this on the website, so I'm not really going to hit on that. We do wellness, so I think we have 3 to 4 wellness events a year. This one here is when we went to Hershey Park last year. Recently we went mini golfing and went out for ice cream. Living in Berks, I'm also going to skip this, but there's a ton of stuff to do, whether you're interested in outdoor stuff or, obviously Philly's very close as well. And New York City is actually only about an hour and a half, or sorry, 2.5 to 3.5 hour drive. I'm going to skip this for time, just kind of where our graduates go. So we've graduated 2 classes now. So we've been around for about 6 years. We've had everyone matched into pain medicine to, interventional pain and spine, spinal cord. We've done sports medicine as well. And then we have residents have graduated and just go on to work in private practice as well. Kind of what our quick interview structure is here. So usually you'll interview with Dr. Sam, our PD. You'll interview with our chair, Dr. Crozier. Dr. Gleason and Dr. Moser will usually give you kind of like some PM&R specific, just kind of scenario questions, and then some other questions if time allows. And then you'll always interview with the resident as well. That's kind of it.